If I MRI scan 100 runners over 50 right now, 60 of them would have a meniscus tear and absolutely zero pain. We treat MRIs like truth detectors, but for the meniscus, they are terrible predictors of pain. Studies show that for most runners, a tear is often just the gray hair of the knee, normal, painless aging, not a surgical emergency. The meniscus is simply two C-shaped cartilage wedges acting as shock absorbers between your femur and tibia. They distribute load and stabilize the joint. But here is the critical twist. Runners get tricked by lumping all tears together. There is a massive difference between a traumatic tear, a sudden twist and pop, and a degenerative tear caused by wear. One might need a surgeon, the other needs strength training. For degenerative tears, surgery is rarely the answer. Research comparing meniscectomy to sham, placebo surgery found identical outcomes after 1 year. Removing the cushion often just accelerates arthritis. So, when can you run? If your knee mechanically locks, catches, or gives way, stop. That's a mechanical obstruction. But if your pain is stable and the joint moves freely, physical therapy wins. To return, you must earn the right. Start with low-impact cycling to flush the joint. Progress to heavy isometric holds to stiffen the tendon, and only run when you can hop on one leg pain-free. Treat the symptoms, not the scan. Run smart.